Allora, buongiorno.
Good morning. To try and understand the right framework when we talk about the clinical picture characterized by GNAO1 mutation, I will present an overview of pathologies with epileptic and dyskinetic encephalopathies where we can find the GNAO1 mutation. As far as neurology is concerned, classical neurology, for many years, what clinicians mainly focused on was the similarities between epilepsy and the mutation of GNAO1. So dichotomy of the interpretation of clinical studies, and this delayed the identification of certain mutations. So some genetic situations were found, and the same molecular alterations manifested both with epilepsy and movement disorders of dyskinetic types at different age of development and sometimes at the same time. And what is more important for us today, there are some situations where there is a constant or nearly constant association. It might not be simultaneous, but it's constant. And this happens in the majority of patients, and this is caused by the mutation of a series of genes, among which we find GNAO1 This happens sometimes in these other types as well, and we will talk about those more in details to try and understand the differential diagnosis. To try and understand why there was a confusion in the beginning, I'll show you a video. This can be easily classified as a dyskinetic attack, but it's actually epilepsy, as well as this other episode that you see on the other side of the screen, this continuous movement activity that sometimes is called the continuous motor restless, which is the absence of capacity of control one's movements that has dyskinetic characteristics when it comes to some movements. And these activities are due to epileptic seizures that are continuous. But, as I was saying, the ways where there is a coexistence that is almost constant are listed here and are linked to the mutation of these genes. As we will see in the final synthesis, these genes code for proteins that have very different functions. We have ionic channels, we have genes that are expressed for the synaptic function that liberates vesicles for neurotransmitters that rule the communication among cells. We have genes that regulate the development of cells that have excitatory or inhibitory functions. We have genes that modify the speed with which synaptical vesicles transfer messages from one cell to another and can regenerate after finishing their function. And then with GLUT1, we have genes that regulate the passage, for instance, of glucose through the nervous system. So these phenotypes are very similar, and they are caused by molecular alterations that are very different among them. For instance, this work surprised most people. This is a study of epileptic encephalopathy, which is the Dravet syndrome, which also there is another association for this disease, and there is a national register for this disease too. And some subjects, all of those who have a specific mutation, a recurrent mutation, present dyskinesias that are very important, as you can see in these videos. which is something that does not happen in the majority of other patients. And this one has certainly characteristics, features that are similar to the children that have a GNAO1 mutation. But in this case, we have very severe cases of epilepsy. This is an observation that comes from the laboratory of Professor Leuzzi that we studied in depth at a molecular level. This is a child that has a deletion of the gene that causes Dravet syndrome, but also other continuous genes that are involved in neurological functions, and at a certain stage of his development presented the dyskinesias that you can see in this video. You see a child like this, you know that he has epilepsy that can have different manifestation, that he has dyskinesias, and if it wasn't possible to study the molecular genetical functions, it would be impossible to understand exactly what he has. This is another kind of mutation of the RX gene. The mutation of the RX gene, as we know, it has many functions, and it intervenes in early stages of development, and it is expressed in GABAergic neurons that from deep areas of the brain. And we're talking a precursor of the base ganglia, which are the structures that manage the movements. And they're also responsible of migration of GABAergic neurons towards the frontal cortex. In studies on animals with ARX mutation, there is a reduced production and migration of these cells. And in the most severe cases, there is also brain malformation according to the kind of mutation. In other cases that are less severe, what is not visible is a true brain anomaly, but children present severe dyskinesias and epilepsy that include infantile spasms at an early onset. This is something that is linked to the X chromosome. It might be family cases when the mutation is transmitted by the mothers that often are healthy, and it manifests with severe dyskinesia that can have an early onset, as in this child, that, as you can see, has infantile spasms, and they can be extremely severe, and they can bring to a dystonic status of the opisthotons that can create rhabdomyolysis and kidney failure. These patients need to be hospitalized, and they land in the ICU. Or other manifestations, as the one you see in this video, that one back in the past were considered to be like cerebral palsy, dyskinetic cerebral palsy. Sometimes the dyskinesia is less severe, and children can develop postural behaviors. As you can see in the last subject here on the right, is a child that can actually move, can actually partly control his body, and can walk on his knees. In this case, too, the clinical expression can be very similar to children that have the GNAO1 mutation. There is another condition that is encephalopathy due to mutation of another gene. There is a protein linked to the function of the syntaxine, and is very important in managing the release of synaptic vesicles and so neurotransmission. These subjects can present early onset epilepsy and dyskinesias that come together with stereotypes movement that can be hard to differentiate.
Un'altra situazione.
Another situation where there is the coexistence of bizarre dyskinesias, as we will see, and epilepsy is the situation where there is the mutation of TBC1D24 genotype-phenotype. These are regressive and not dominant, as we have seen so far. And in the past, they were known for myoclonic, the presence of myoclonic episodes. As you can see in this video, these are subjects that show very fine myoclonias, and they can also present severe cases of epilepsy. This is our own study that dates back to 1999, and we associated other forms of dyskinesias. They were induced and aggravated by the movement, for instance, so walking, or as we saw, they were aggravated by an effort, by a movement, such as the movement you have to do to write. Writing implies a huge capacity of distributing in a perfect way the contraction of muscular groups in the arm. So it's a very complicated movement, and writing is a very specific activity that can help us understand what kind of dyskinesia the subject has. As you know, this kind of dyskinesia is present in people who play the piano or who play the violins, or those people who actually use their hands in a specific way. Here we have a sister, a brother, and a cousin, and you see that with a different latency, they cannot write any longer. Not only that, but they also said that to walk in the morning, for instance, to go to school, they had to stop every now and then and rest because legs were too stiff to be moved. This thing was studied by us, and it was correlated with the mutation of TBC1D24. So as you can see, one gene can cause different clinical manifestations that are hugely different among them. There was a family clinical case and other cases of myoclonic epilepsy associated with dystonia and forms of a very severe epilepsy with migrating seizures and other manifestations. These are the patients that I was talking about in our study. And besides the dystonias that could be seen, they also showed epileptic seizures. As you can see, she tries to write, but she can't. And here, after walking for a while, we're talking about walking for 40 minutes, we were able to evoke a dyskinetic crisis, and as you can see, she has a contraction of her limbs that doesn't allow her to maintain an erect posture. Showing this data during a congress, and this is how it works with rare diseases, we came into contact with other clinicians from the United States and from China that showed us patients very similar to the ones that we saw in the family case that we studied. This is a child, a baby girl, that shows epileptic seizures. They're very similar to the ones that we saw in the other subject. And in a context, this is during a school show, she shows dyskinesias. She manifests dyskinesia. So this allowed us to carry out a study to identify what are the neurological bases of these diseases. When the mutations belong to the same department of the protein that manages the oxidative stress, the result is that synaptical vesicles are engulfed, the change and the reproduction is slowed down, and this is probably what happens. I'm sorry, this is the wrong slide. So this is what happens with this patient, and there is a deficit. However, conditions that associate epilepsy and dyskinetic disorders not often can be treated, although this is something that the clinician cannot see right away when he sees the patient for the first time. But the study of the PRRT2 gene mutation, we see how it can actually be treated. And there are other features here, for instance, hemiplegic migraine, and there can be movement deficit that can scare patients and their families because they're very similar to other kind of deficits. But dyskinesias in these cases are paroxystic. This is Professor Leuzzi's video. It's very clear, it's very evident what we're seeing here. And we can see how this can be the same thing that we observe in children with the GNAO1 mutation. And sometimes, as you can see, dyskinesias have a very early onset in very young children that can also have epileptic seizure. The graph that you see belongs to the same child. And they can also be an obstacle for walking. As you can see, this child is very unstable. And as you can see, there's also loss of balance all of a sudden. However, this disorder is benign, is very typical of the infantile age. And these subjects, for reasons that we do not know, they heal, they are healthy, they might transmit their disorder to the following generation, but this is not very worrying because we know that the symptoms will go away, will disappear. An important manifestation with the association of epilepsy and dyskinesias is what we will see in a minute. This is our own study that we carried out in 2002, where we were very surprised by seeing the association of absences, typical absences of epilepsy, children that all of a sudden loses contact with the environment associated with paroxysmal dyskinesias. And the absences had a very early onset. We're talking about 1.5 years or 2 years of age. And then the following studies have associated this syndrome with a mutation of GLUT1, a gene that manages the transfer of glucose in the blood. This is a facilitated transportation, and the level of sugar that is available for the brain is not the same that is available for the blood, is lower, but must be constant and sufficient and must be managed by a transportation that facilitates the transportation through the brain membrane. If this is altered, it means that the brain has less sugar available, and the result is dyskinesias that can be very severe and that are even more severe during exercises because the supply of sugar is higher. This discovery allowed us to identify a specific cause, and as we will see, also specific therapy for these patients, progressively widening the number of associated phenotypes. This is an example. We have very severe alterations on the EECG. And unfortunately, we cannot see the video very well because there's too much light, but this is a 6-month-old baby girl that was showing dyskinesias of the head and the eyes. This can be cured simply through diet, through a ketogenic diet. A ketogenic diet allows ketones to have access to the nervous system where they are metabolized, and they provide energy, and that goes and compensates the lack of glucose. The answers, as you can see, are very severe, dramatic. This is a very altered EECG. And we also see a manifestation in movement disorders. I'm not going to talk about GNAO1 because everybody else talked about it. This is our study, and this is the reason why I'm here today, because we collected data from different subjects, and we had a collaboration that could be only international since we're talking about a rare disease, and this describes a certain number of patients, and we have widened the number of clinical observations and mutations that are associated with this. But Professor Valente will talk about this. I only wanted to show how in these patients, and we're talking about 7 patients here, there is a constant association of movement disorder with early onset, 4 months, 7 months, 8 months. But even 5 years of age, we have registered an onset at 5 years of age of movement disorder. And this is the same with epilepsy that arises at different ages, sometimes very early, some other times later in their life. And here we have a video of our patient that started to. This girl had many problems. She had a brain tumor that was operated. She had epilepsy, but the most typical manifestations of GNAO1 mutation started when she was 16 years of age, and they're limited to mouth dyskinesias. Just a few words to describe. Another syndrome, FOXG1. It's a repressor of transcription that intervenes in brain development. And the subjects, the patients that are affected by this disease, show a severe deficit. Often they do not develop their speech, and they can have an early onset epilepsy, and they develop a continuous dyskinesias that sometimes can be overlapped with stereotypes, which make them look like Tourette syndrome. And here is where clinicians get confused, because these are 2 different things. And here we have more severe cases. So I will stop here, reminding you that movement disorders can be induced by AEDS. This can be side effects, and we must remember this, because if we have a severe epilepsy and then we have dyskinesia, it might be caused by the use of a drug. And I will wrap up saying that, when we talk about benign form, there is a paroxysm, whereas in more severe forms, it's a permanent type. So I will stop here, and thank you very much.